Ladies and gentlemen. A little bit ago about what happens in while we need a patent airway. So remember what patent means. Patent just means open. So we need an open airway. Number one cause of airway obstructions in upper airway. Tone, yes, very good. So if we have anything that's impeding airflow from outside air to our lungs, it's going to be problematic. Now we looked at some general mechanical process of moving air in and out, mechanics of ventilations, etc. So what about those airways that are occluded that may be problematic? So you could have a burn patient. So if you have this burn patient, which you see here on the left, our problem with burn patients is just like those patients with asthma. So we see all the burns he has here. Somebody has singed nasal hair, singed facial hair, anything, and we're going to assume that heat has made it into the inside part of a nasal cavity or oral cavity, etc. And when burns exist, burns swell. So we have visible burns we see on the outside. Those inside burns may not be as visible. So we're going to have to anticipate that this patient has airway burns. Remember, it's always best to suspect the worst than underplaying the injuries. So if we have swelling, notice here, then that trachea is going down. We're going to have airway swelling in our tissue. And then our soft tissue here, you're gonna have airway swelling in the back of the throat, maybe the nose. And then you start looking at any swelling in down our upper airway tract, even down into our lower airway tracts. The image on the right could be associated with trauma. So how would you manage this airway? So this airway is pretty severe, but one thing to note is do not be distracted by a patient's injuries. If you get distracted by a patient's injuries, you get more focused on them than you do what's happening with their vital signs. Or you think you need to really handle this because oh my gosh, it looks bad. But no, what's bad is he's not breathing. So we're going to fix that and then worry about this. So those are called distracting injuries on our behalf. So anything that distracts us, any injuries that distracts us from taking care of the patient. So we can be so focused on an angulated fracture or a messed up leg injury that we are not focusing on airway, breathing, or circulation. So how do we know when an airway is open? So when you're doing your airway assessment, so you look, listen, and feel for breathing. So if you've ever heard that, look, listen, feel for breathing. So as you approach your patient, you want to, in the case of our case study, so patient has shallow respirations. How do we know he has shallow respirations or shallow ventilations? So shallow ventilations is we're looking at obvious chest rise and fall. If we do not see the obvious chest rise and fall, then we're going to assume that airway is not good. So he's having problems with tidal volume. So if he cannot maintain tidal volume, he's not maintaining minute volume, he's not maintaining VLR volume. So if we have somebody with shallow respiration, so look, listen, feel for breathing. We're looking for chest rise and fall. We're listening for, so when you are doing your assessment, and I don't have a mannequin here with me to show you, but imagine this patient's head being here. So we're looking for chest rise and fall. We're listening for air movement, and then we're also feeling for air movement. So feeling for air movement is any expired air. So look, listen, feel for breathing. So signs of an open airway, air can be felt and heard moving in and out of the mouth and nose. Patient is speaking full sentences with little difficulty. The sound of the voice is normal for the patient. Abnormal upper airway sounds include snoring, and again, snoring was occlusion usually by the tongue, crowing sound, a gurgling sound, or stridor sound. Now, just take a moment when you look at I'm gonna play each one of these: snoring, crowing, gurgling, and stridor. So signs of a blocked airway: abnormal upper airway sounds, stridor, snoring, crowing, or gurgling. So gurgling sounds the fluid or some type of liquid that's in the throat that's it's going to cause it to gurgle. So we need to clear that. An awake patient who is unable to speak is a sign of inadequate airway. Evidence of foreign body airway obstruction in tongue, vomit, blood, or teeth, an upper airway, mouth, or nose. So we need to manage that, remove that object if we can through suctioning or depending on how much vomit is there and how much fluid is there, you may just need to turn your patient on the side and do a sweeping motion just to get it out, and then do a suction. Swelling to the mouth, tongue, or oral pharynx. So I want you to watch the videos listed below and airway assessments and process of opening the airway using the scissors technique. So scissors technique is when you have your patient and their mouth is closed. So what you would do if this is your patient is right opposite, just like a pair of scissors is, with your thumb, you're pressing in on their upper jaw, your index fingers on their mandible, or at least on their teeth, and you want to do the scissors method, opening the airway like so. So we do the cross fingers technique or scissors technique, clear the airway of liquids and foreign bodies, make sure a patient's placed in a open airway maneuver, so either head tilt chin lift or modified jaw thrust, and those videos are there for you to look at. So what we would do as far as opening airways, manual maneuvers, which we just talked about, we would suction, and then we would use mechanical airways, or the use of an OPA or the use of a nasopharyngeal airway. In the state of Alabama, as EMTs, you will be allowed to use supraglottic airways. Now, your book doesn't talk about these until later on in the chapter, or later on in the text, but supraglottic airways are considered an advanced airway that is allowed to be performed by EMTs in Alabama. So a supraglottic airway is an IGEL, or could be a King airway, or laryngeal mask airway. So what's happening with those techniques is we're inserting a rigid tube down to their throat, and basically, and then what we're doing is occluding the airflow into the gastric area, and we're minimizing the ventilation backflow, so any flow is coming back. So what we're doing with those supraglottic airways is concentrating the amount of ventilation as our glottic opening. So those are your supraglottic airways, and you'll have time to practice those.